And hello, and welcome along. This is Kathy Frey from IMCO, from the International Integrated Maternity Healthcare Organisation, and welcome along to this week's live webinar on our Maternity Natural Health series. And it's actually myself here today with another from IMCO, another midwife from IMCO, a very senior lady called Anna. But Anna has been having problems with her internet. So right now it's just me, but that's okay. We're going to progress on with this topic today. And what we're going to be talking about is postnatal depressive disorders, and basically that holistic approach to preventing postnatal depressive disorders, identifying them and treating them. So what I'm going to do is start with sharing my screen. Okay, so just give me a moment. We'll get this up and running. And share screen. Right, so welcome along. And what we are talking about today is postnatal depressive disorders. And when Anna comes in here, I will introduce you to her as well. And so my little background as far as my knowledge here is that I'm a senior midwife, and I have been my country, which happens to be New Zealand, but I've been my country's #1 best-selling birth, baby, motherhood author since about 2005. So that's a little while. And this is actually one of my real pet love topics. Pet love as in that the more information a woman receives, the more guiding support that she gets on this, the more preventable this experience is for her. And the scary thing is that around about 1 in 3, so about 1/3 of all women will experience a postnatal depressive disorder, which is horrendous. But and in some stats you will find it talking about 1 in 4, but I disagree. I think that 1 in 4 is those that get diagnosed and sort of somehow picked up in the system. I think it's actually 1 in 3 on the front line. So we are gonna get going and talking about that. So the first thing I want to talk about is baby blues, because that's often a really misunderstood part of the postnatal depressive experience, except the difference with baby blues is it's not abnormal. So it's a very physiological, it's a very normal, a very common event that usually starts on around about day 2 to 3. And this is a normal experience after having a baby. It happens to about 8 out of 10 or 4 out of 5 mums. And it's really purely hormonal, pretty much, apart from the fact that, you know, you've also just gone through quite an emotional roller coaster, having given birth a few days before as well. And you probably also really got quite a sleep accumulation of sleep deprivation over those last few days as well. But the real, so I've got a list there of symptoms that you can will be familiar with, probably most clinicians, you know, bursting into tears, being kind of fragile emotionally, and, you know, little mood swings, just a real low spirits. And as midwives, when we see women getting a little bit teary-eyed on day 2 or day 3, that is when we kind of rub our hands together in glee and go, yay, the milk is coming, because it is a sign that things are progressing normally as they should, and that within probably about 24 hours or so that her milk is going to come in as a good supply. So baby blues is normal, and women need to be mentally prepared for the fact that they are going to get a little teary-eyed on around day 2 or day 3, and that this is not them not coping, and this is not them not bonding. This is purely hormonal. Once that placenta came off the wall of the womb, the estrogen in a woman's system goes down by over 1,000% in that next sort of 48, 72 hours. So how could you not be a little bit teary-eyed if your estrogen goes down by over 1,000%? So yeah, it's just a normal experience. But you know, about 1 in 5 women don't experience it. But this is another area where it's really important for the partners to be aware that this is going to be coming, so that they're not shocked by it as well, or concerned by it, you know. So we also have something called the baby pinks, and these are abnormal and rare, and really quite pathological. So it's a real warning. If we start, instead of seeing somebody suffering through the baby blues, if some women start to have the baby pinks, where they are just way too happy, over coping, and are kind of illogically on top of the world, being sort of way too capable, way too peachy. You know, she's at the supermarket the day after giving birth. She's having sex within the first week. She's not eating properly, having difficulty sleeping, or refusing to rest enough. And when somebody's in the baby pinks, they should be very carefully watched, because it can be a little bit of a red flag for a pending, far more serious depressive imbalance, particularly postnatal psychosis. So yeah, if you've seen somebody who's just illogically way too energetic and happy and bouncy, and yeah, keep a little eye on them, because they can get very rapidly worse. Okay, so the next one we're going to talk about is PTSD, or post-traumatic stress disorder. And this is, again, it's pathological, not physiological, of course. It's not uncommon, but it is never normal. And the thing with PTSD is that the symptoms of it have 4 quite specific characteristics. And so those 4 characteristics are intrusion, avoidance, hyperarousal, and self-medication. Oh, we've got Anna here. Can you hear me, Anna? Okay, I'm carrying on.
Yes,
so,
I can.
Oh, good. You're a little bit delayed, but that's wonderful. So we've just got up to talking about PTSD. No, don't apologize. It's this is just what we deal with in an internet world. Sometimes our internet isn't so great. So there's 4 common characteristics of PTSD, as they are intrusion, avoidance, hyperarousal, and self-medication. So intrusion are those sort of memories of the trauma recurring unexpectedly. So it's almost like somebody is having you know, some vivid flashbacks of it, you know. So she's sort of she's in the middle of washing the dishes, and suddenly she feels that trauma again flashing over her, and taking over her. And of course, with PTSD, you know, birth can be a dramatic and traumatic event for a woman, and unfortunately, too commonly so, particularly when we've got involvement of instrumental deliveries of ventouse and forceps, vaginally, and very much so a woman getting rushed away for a emergency C-section. Now, the crazy thing with PTSD, well, not crazy, but reality with PTSD, is that oftentimes when a woman has walked away from PTSD, from a childbirth experience, if she is able to debrief really well. Sit down with the people who are at that labor and birth, go through what happened, why this occurred, why that medical management of the situation occurred. You know, if she really explains what happened, often she can end up with actually no PTSD, because she's not feeling out of control when she's involved and everything's well explained to her. And a sad fact is that often for the obstetric staff themselves, the midwives and the obstetricians who may be attending her labour and at her dramatic birth, delivery, for them, it's not traumatic, because heck, it could be the third ventouse they've done today, or the second emergency C-section, or the sixth emergency C-section. It's almost a little routine, sadly, in some hospital situations. So for them, it's not that traumatic. And yes, you know, there was an obstructed labour and a failure to descend, and there was a bit of fetal distress going on, but nothing that extraordinary. They've certainly dealt with much worse in their career. But for that woman, that was mind-blowingly scary. And so often, you know, when you sit down and you debrief with women afterwards, particularly maybe even 2 years down the track, and they're pregnant with another baby, and all of this is coming up again, and you know, they've got reasonable levels of reality as to why they should be kind of pretty scared and frightened about what's happening for them, because based on their previous experience. And you know, I've so many times I've sat down with women with their notes where I'm new to looking after them because they need a fresh start emotionally. So they want a different midwife or obstetrician who's going to be on their team. Not that the previous one did anything wrong, but it's about having a clean, fresh start for them. And you sit down with their notes and you explain what actually occurred. And when they realize, particularly something like fetal distress, but the baby wasn't just about to die, the fetal distress was just showing on the CTG trace that, you know, this baby was starting to get a little bit tired. It was getting a little bit less reassuring, and it was fairly obvious that the baby would not be happy continuing on with that labor for another hour or two. But it's not necessarily that the woman, you know, that their baby only had minutes to live. So, you know, fixing those sort of bits of trauma can be so healing. So just going back to those other characteristics. So you have intrusion, which is like flashbacks, avoidance, which is basically the woman going out of her way to not expose herself to that. So it might be a case that she just doesn't drive down that road anymore where the entrance is to the hospital. You know, she just prefers to avoid that, and then it doesn't trigger her, and she doesn't have those thoughts again. Hyperarousal can be when the person can be sort of feeling suddenly a little explosive, when that's not really being justifiably provoked, and obviously self-medication. So yeah, turning to alcohol and drugs, which is tricky when you're trying to breastfeed. So women, you know, can sometimes wind up their breastfeeding a little earlier because they just feel like they need a drink because they've got PTSD, which is a real shame. Anna, I can see that you're there. Can you hear me okay?
I can hear you okay. I feel like my line is unstable though, and it keeps dropping me. So I don't know if I should kind of hop in or if I should just let you finish, because I'm afraid I'm going to get thrown off again.
No, well, no, stay on if you can, and then, I mean, hop back in. But while we've got a stable connection, is there anything you want to add about PTSD?
The only thing that I would say is that it is an anxiety-based disorder. And so, especially in my practice, I've seen women that have already in kind of anxious personality. When they do end up having something that goes, slightly out of the norm, they tend to be triggered much easier. So it's almost as if to say that if someone does have an anxiety disorder, just be aware of that, and be able to almost, I feel like these are the women that really need things to be explained over and over and over again, and just the time, you know, that would probably be the only thing that I would add.
Yeah, you're absolutely right. You can, yeah, they are sort of line a little bit red flagged for that to happen. Actually, while we've got a stable connection, I ended up introducing myself. We were going to introduce each other on this, but while we, yeah, could you just reintroduce yourself and give everybody your background as well?
No, I didn't necessarily understand everything you said. Sorry.
Oh, can you reintroduce yourself?
Oh, sure. Yes. So I'm Anna Mejia. I am a midwife, 12 years now. Was trained and educated in the United States, have worked in and out of hospital. And
Oh dear. Okay, she's frozen again. All right, we shall carry on, but it's good. We all just understand and appreciate technology. Okay, so the
sorry.
next one. Oh, you're back. You're back. Carry on
It keeps
talking.
So I've been practicing for 10 years and 10 to 12 years, I should say. And I'm really excited to be doing something kind of out of the traditional role and focusing more on online work, and trying to expand really the walls beyond our traditional four walls in our office to try to reach out to more women. That's me.
Fantastic. And yeah, and Anna has generously recently joined the volunteer team here at IMCO. She's another one of our international midwives who are doing work behind the scenes, and we couldn't exist without our volunteers. So it's very exciting to have you here.
Thank you.
So
Thank you for having me.
yeah, totally. So the next topic, the next disorder that we're going to talk about, which is the one that we'll talk about in a little bit more in depth, is postnatal depression, because that is the commonest one. So it's pathological and it is very common, but of course it is never normal. And the thing with postnatal depression is that there are a number of symptoms, and it's varying degrees of symptoms, and it varies for every individual. And in actual fact, I have for you here 3 slides just on symptoms. And obviously women are not going to have all of those symptoms, but they're going to have some of them. And oftentimes the symptoms can be quite almost polar opposite of each other. So I am going to just run through them kind of quickly because it gives you a little bit of an overview. But the slides are very wordy, and not that we're going to be reading them all today at all, but they're wordy so that they become a reference for you, so that you as viewers of this webinar are able to pause the screen and have a jolly good read, basically. So yeah, postnatal depression. So it is when a woman is miserable, depressed. There's just an unrelenting sadness. She can be very tearful, sort of crying all the time type thing, and feeling immense shame, low self-worth, unrelenting sort of self-guilt of just crippling failure to feeling that she's failing, and a real plummeting self image and self-esteem, and feeling kind of just overwhelmed by it all, you know, but difficult to cope. There can be a bit of, you know, a side effect can then be some confusion, being a bit indecisive, a real loss of optimism, feeling a bit hopeless about it all, feeling that she can't express it, her, you know, then there's this like conflict of going, oh, I'm upset at myself because I'm feeling so ungrateful, where I should be grateful that I've got this happy, healthy baby. So it's a real sort of juxtaposition of kind of being pulled with emotions all over the place, feeling anger or resentment, feeling tired or exhausted, irritable, hypersensitive, like a feeling like there's no light at the end of the tunnel. Definitely hard to look forward to social events because you sort of have to put on your mask a little bit, and lacking interest, having no interest, feeling alone and remote, feeling yourself and your loved ones, fearing of contact with other people, loss of vocabulary. It's like you just actually, and I mean that could just be part of the whole pregnancy postpartum journey anyway. You sort of, I always felt like I lost nouns. I just couldn't name anything. Everything was called thing. Could you get the thing and put it on the thing? Because I can't remember what anything's called. So that could be common anyway. Poor appetite, and compulsively over obsessing about everything. So that can be just having this like hyper tidy household, or it can be the opposite of being uncharacteristically messy, and it's really that change which is the big red flag. Worsening tiredness, anxiety, disquiet in the evening, insomnia, wakefulness, you know, just not sleeping well. And you're not sleeping well anyway because you're waking up to feed a baby, but it just, you know, is even far worse than that. Feeling like a cross between someone who's about to have a nervous breakdown and just a plain old nasty person. You just wonder where you went, where the older you went. Feeling unbonded or not in love with the baby and guilt over the fact that you're feeling that way. Bearing in mind that bonding is not something that occurs like super glue instantly as soon as that baby's born. You're glued together and bonded. It doesn't happen like that. Bonding just gradually unfolds. And being sort of overactive and never stopping because it can numb the pain, perspiring and having almost starting to get heart palpitations through that anxiety and stress, talking all the time, even when hardly anyone's listening to you, having no interest in sex, or becoming obsessed with getting off on sex. So again, it's those polar opposites. Increasing self-medication, things like alcohol and drugs, blaming yourself, feeling worthless, believing that life events are beyond your control, panic attacks, feeling scared, frightening, recurring thoughts, hair loss can start to occur when it's been going on for a while, and having potentially harmful or violent thoughts towards the baby. Now we're sort of starting to creep into psychosis, but you have the thoughts, but you are in control, that you know that you wouldn't do that, and you just kind of want to shake the baby, but you know not to, and you won't be doing it. Having suicidal, wish I were dead thoughts, and just at the opposite end of the spectrum, just unable to feel anything. And so that's all. You can pick up the fact that it's so broad and it's so unique. Sometimes I would say to women, you know, it is not normal to feel happy all the time. So it is absolutely reasonable to, you know, have periods through those first 6 weeks, particularly, and over the first few months, where you are grumpy, you are tired, you are exhausted, you are over it, and you're not going to be happy all the time. The important point is that you are feeling happiness at some time every day. You know, there are moments in the day where you can genuinely, honestly, hand on heart, feel happy. And, you know, it might be that special, amazing moment when your baby just looks at you with an adorable little grin, or does this huge burp and you laugh your head off, or, you know, you feel joy in some moments. And as long as you're feeling genuine, heartfelt, I love that, joy in some moments every day, then chances are you don't have postnatal depression and you're just a tired, busy mum. But if you just have got to this point where it could be Christmas Day and it's wonderful and everything's fantastic and your baby's being beautiful and your husband's being charming and the family being great and any other children you have are being well behaved, and it's a great day, and actually deep down inside you're seething. You're pretending to be happy, but you're not. You're angry. Or, you know, that's when you're going, this is not normal. This is not usually me. And it's a big red flag. I've talked a lot there, Anna. I'm sure that you've got a whole lot to add. What's your commentary on postnatal depression?
You know, I think that we just need to, as providers, you know, really stop and really, you know, ask kind of heartfelt questions and not breeze over this, because I find that a lot of women will come, you know, back for a new prenatal visit with a new baby and say, oh, I think I suffered from postpartum depression with my last child, and I just kind of chugged along or like pushed through it. And you know, it's so unfortunate to hear that, because you know, there's bonding that's being missed out on, and I don't think anyone should, you know, have to live, you know, kind of in that just such a stark place when it's such a good, you know, happy time in their lives. So I think that, you know, it's one of those postnatal depression. It's so common and so you know, and sometimes it's almost seen as it's normal when really it's not. You know, we really have to dig a little deeper to try to really understand and help women kind of be able to, you know, identify it, because some women don't even necessarily can identify it themselves.
You're absolutely right. And I know that for myself and my own experience, when I had my third baby, yeah, I knew, I could feel it. I was going, I am not right. I'm so angry at everything, and I'm not normally an angry person, but inside I was. And I remember talking to my GP, you know, local community MD, and him saying, you know, it could be postnatal depression. And I wasn't a midwife then, and I was like, no, look, it's nothing to do with the baby. Like, the baby is the best, like having the third baby is the best thing I've done. I'm wrecked with the baby. It's everything else that's going on, which is why I'm upset. And he was like, might be. And it was sort of like, well, why don't you just try these tablets and let's see if it makes a difference. And it made a huge difference. And the thing that I realized is that I had some postnatal depression after my second baby, but it was mild enough that I couldn't fully pick it up. And it was the third baby that kind of tipped me over the edge. And again, it was nothing to do with the baby for me. It was all to do with everything else, because we had other stresses going on in our lives, and you know, some other big deals outside of our marriage and our children that we were having to deal with. But the fact that it wasn't until I had the third baby that I realized that I had a mild version of it with the second baby. So you are so right that it's like it's sometimes the women themselves just don't realize, because we'll put it down to being the logic that we're tired and we've got not just the baby, but we've got another child or 2 or 3 that we're looking after.
Mm.
And there can be such a vicious cycle with the sleep deprivation that occurs as well, of course, because you've got, I'm just going to move the slide on here so that people can be looking at the next one. But, you know, what happens, of course, is we make our serotonin, which is our neurotransmitter that allows us to feel happy contentment. We produce that serotonin mostly while we sleep, so that the next day when you wake up, you've got a full tank of serotonin, so that day you're able to experience the emotion of happy contentment. And when we are sleeping poorly, we're not producing that same level of serotonin. So the next day, because we're a bit low in serotonin, you know, our body will go into the adrenaline type of fight and flight sort of mode, where we are coping with stress, coping through our body producing a lot of stress coping hormones like cortisol. And so then what happens is that night we try to go to sleep, and it's difficult because we're so full of stress hormones, and that impacts our biorhythms, and we can't get to sleep so well. So then you're not falling asleep so well, and you're not producing the serotonin. So it becomes this real vicious cycle, doesn't it, Anna, where the more stress you have, the worse your sleep, the lower your levels of the serotonin, which makes you then have more stress hormones and have worse sleep and making less serotonin. So it becomes this absolute vicious cycle, which is why oftentimes, you know, supplements or medication will be that it's almost like putting a knife into the spoke of a turning wheel, and it stops it, and you can, restart the engine a little bit.
Yeah, that's a really good point, but so true.
Do you, before we go into some of the supplemental treatments, do you want to go over anything more to do with, the general symptoms or awareness of postnatal depression?
I would just say that the biggest difference is, especially with the baby blues and the postnatal depression, is really just the baby blues tend to be, you can get in and out of it. You have periods of you're very happy and it lasts a lot longer. With depression, it's just kind of this ongoing, there's no kind of happy moments that kind of break through that sadness. It's just an ongoing kind of feeling. So that's, I think, one of the biggest differences with like the postpartum depression and the baby blues, which sometimes I feel like can be a little confusing. Especially like some women will come in after 2 weeks and say, oh, they're still having some postpartum or some baby blues, and typically it doesn't necessarily last that long. So as providers, we need to kind of be aware of that and try to sift through that, help them sift through that.
Yeah, absolutely. Okay, so we've got now 3 slides that we're going to go through about some of the supplements that are out there, because really from a doctor, pharmaceutical, drug prescription perspective, really pretty much the only thing they can give you is an SSRI. Well, there are other antidepressants, but SSRIs are the ones that they tend to prescribe for postnatal depression, which is a selective serotonin reuptake inhibitor. And, that's strong medication. So there, in my experience, there are stepping stones that one can use that sometimes can nip things in the buds beautifully without needing to go on to an SSRI. And the thing with the natural supplements is, of course, they just don't have all those same horrible sort of side effects that all pharmaceutical medication will always have. There's always adverse reactions or side effects to every single pharmaceutical drug that there is, and it's basically that happens because pharmaceutical drugs are synthetic molecules, and when you put a synthetic molecule into your body, it will have a reaction, and it is those reactions which is what it's prescribed for, but it will also have some reactions which are not helpful, or whereas with any ingredient that is found in Mother Nature, unfortunately, or fortunately, pharmaceutical companies can't get royalties on those. So if it's a natural molecule, then they can't get their royalties. So they tend not to be spending money on researching them because they're not going to make royalty money on it. But they will be researching them sometimes to go and create a kind of a synthetic version where they'll alter that molecule just ever so slightly and say, oh, well, there we go, we've created it, so now we'll have our royalties, please. So it is the problem with natural supplements is that they do suffer from the fact that there just isn't huge amounts of research money that's available to plow into them, to do fantastic huge double-blind trials all over the place. Like, who's paying for it? Because nobody's going to make royalties out of it. So it's a little bit tricky, but a lot of the therapies that we're talking about here are basically have been proven over a long time, so hundreds and sometimes thousands of years of use, and we just have to pay attention to that. So one of the first things that we've got listed there is obviously counseling, psychotherapy, hypnotherapy, etc. So that definitely has its place, but I would say that in my experience, that's kind of the last thing that a woman with a fully exclusively breastfed baby can necessarily fit into her life, or necessarily afford, or have access to. So yes, it can be helpful, but it's not always very accessible. And so the next one we're going to talk about is a product called Gota Cola, and this is one of Ayurvedic medicine's primary rejuvenative herbs. It's also called Brahmi because it brings the knowledge of the Brahman. So it's a real food for the brain type supplement. So really good for if you just feel like perhaps it's less of a depressive thing and it's just more of a general brain fog. St. John's wort is one that's quite well known. Often, women will mention that one. And was used in Europe for hundreds of years to chase away melancholia and anxiety. Melancholia is an old word for sort of unrelenting sadness, really, and anxiety. One thing is that it is contraindicated with the contraceptive pill, so there is an interaction there, but so long as you're not on the contraceptive pill, then that's fine. It's a mood enhancing natural antidepressant that increases serotonin and increases dopamine, and in fact in some Western, particularly Europe countries, it is more popularly prescribed than pharmaceutical antidepressants, because some countries, your general medical doctors and GPs are able to prescribe not just pharmaceutical drugs, but also naturopathic medications. I think the thing to sort of be very aware of with St. John's wort is that it does take a full sort of 6 weeks for its optimum effectiveness to become fully apparent. So it's not a take it today and feel better tomorrow medication or natural medication. Is there anything there, Anna, that you want to add into those ones?
I don't think so. No, I don't think so.
Okay, cool. So the next 3 we're going to talk about is ginkgo biloba, Siberian ginseng, and 5-HTP. Ginkgo biloba is said to be, and it's the ginkgo biloba extract that is a natural mood enhancement supplement. It's very effective for treating depression and mental concentration with almost immediate effects. So that's a really good one to sort of have up the sleeve, really. You know, it's something that is quite good to potentially be taking in the morning and maybe in the afternoon. You know, it's just sort of see you through the day. It just levels everything out, and it just gives your body that little tonic that it needs. Siberian ginseng is not what they call a true Panax ginseng, but it is an amazing mood enhancement supplement that gives really marvelous protection against stress. It helps to combat depression, insomnia, moodiness, fatigue. It really balances those neurotransmitters, which ends up sort of helping to increase mental focus. One of those things are things that can go kind of pear-shaped or feel like they go pear-shaped in that postpartum period. One of the things I found with, I would have to say Siberian ginseng is one of my most personal favorite products to recommend for women to combat postnatal depression and to prevent postnatal depression. For a woman who has a history of depression or a history of postnatal depression, then I have often suggested that in that last month or so of pregnancy, if they were not taking it earlier, and that they take it right through that first month. So the month before the baby's born and the month after the baby's born, bearing in mind that we never know exactly where the baby's going to be born. But, you know, if we sort of look around that sort of 60 to 90 day period, and I have had many women who have had horrible previous experiences with postnatal depression, have zero experience the second time. But it seems to be a very, very good preventative for it, leading up to that birth and after the birth. Usually, you know, the containers come with you know, a month or 2 or 3 months supply, 30, 60, 90 days supply type thing. Good to take them in the evening and, you know, one at night type thing, if that's the dose on the packet, depending on the potency of the particular capsule. But I would recommend that anybody that's got a history of depression or history of postnatal depression, that they do get a 60 or 90 day supply and start it, you know, before they are in labor. The next one is 5-HTP, and this is a really interesting, another kind of one of my favorites. 5-HTP is the intermediate metabolite or the precursor to 5-HT, which is serotonin. So this is an amazing little natural supplement that is so great at helping to regulate mood and combat sort of that mild to moderate depression. It's very good for easing sleep deprivation. So basically, if you take the 5-HTP in the evening, in the next day when your body is going, right, I need some serotonin. If you were a bit low on it, you've now given it the precursor metabolite that your body can convert the 5-HTP to 5-HT. So it's a real instant fix. I used to use 5-HTP. I'm not doing 24/7 on call anymore as a midwife, but when I was, that was always my go-to, that if I had missed a night's sleep, and so that next day when I'd be going to bed, I'd always take some 5-HTP because I knew that my serotonin would logically be down because I'd missed a night's sleep through a birth, which as an on-call 24/7 midwife would routinely happen once or twice a week. So it's also a favorite product of, say, flight crew and shift working crew, because again, anybody that's sort of having this whole normal sleep routine really screwed up, it's a very good instant fix. Take it tonight, tomorrow you're going to feel a little bit, more normal. And another favorite place that I've found 5-HTP use maternity wise is for the partners. When those men folk, sometimes the women are chilled out and relaxed and coping quite well, but actually their partner has found themselves going into this hyper anxious mode of almost like such love over their baby. They're like worried about this and worried about that, and the partners are starting to have potentially postnatal depression or postnatal anxiety plus. And so 5-HTP is great for the guys, and just takes the edge off it. And I've had a few men very gratefully thank me for suggesting that they use it, because it just calmed everything down for them. And then the last ones we mentioned is SSRIs, which of course are the pharmaceutical medication. The thing with SSRIs, selective serotonin reuptake inhibitors, is basically what they do is they alter the cell structure. That is why they take 4 to 6 weeks to take full effect, and that is why you should never, ever cold turkey off an SSRI. And because you really should take at least 3 months to dial down your usage of it, to gradually wean your body off it. So if you can imagine that the synapse or the gap between every neuron and the next neuron, clinicians will know this, there's this synapse or gap in between it, and that's where the serotonin is, and that's where the receptors sort of suck the serotonin into the body, into the cell, so that it becomes effective. And how SSRIs work is that they migrate those receptor cells deeper into the neuron, so that the serotonin hangs about in that synapse gap longer. So that's why we're saying that it's called a serotonin reuptake inhibitor. So it makes the serotonin last a little bit longer. But, the side effect of that is that if you suddenly cold turkey on it, then that can send you into a worse depression than you were in to begin with, and quite quickly, within 2 or 3 days, can be in a horrible place. So never ever do that. And Korean or Chinese ginseng, the name, these are a Panax. The name Panax ginseng, this is a Panax ginseng, it means cure all. And Panax ginseng has a very gentle and slow and cumulative, sort of very broad healing effects on energy. So for the mind and for stress and many other aspects of physiology. So this is a lovely supplement to just take generally in one's life. It's got a lot of benefits, but those benefits are cumulatively, and they take time. And just a note there that natural white ginseng is steam processed to produce the higher potency red ginseng, if you're wondering what the difference is. And then the last thing that we've just got on the slides there is 5 natural supplements which are particularly used a lot around woman issues, maternity issues, menstruation issues, ovulation issues, just anything that's sort of female based. These can be particularly good. So that's false unicorn root, chaste tree berries, shatavari, evening primrose oils, and damiana. And so we're not going to go into details about those, but those are just ones that it might be useful to look up if you think that it's not a situation of depression, but it's a situation of just general kind of feminine things. So that's a little bit of a quick overview. And I really must hand over to Anna, because I know that she's going to have commentary on this.
I would just say turning to the different supplements can be so helpful, and not necessarily, I feel like in the US, we typically just start women on SSRIs. And I feel like, you mentioned some really great ones that I feel like is a great place to start, that can hopefully get someone in a little bit of a more balanced place to be able to kind of take it from there. So I think that's probably the only thing I would say about the postnatal depression treatment.
Yeah, and it is, I mean, that's the thing, is that the doctors just don't have any other options, do they? And that's the thing. It's the SSRI is typically the only prescription that they can write. It's the only tool in their toolbox. So, you come bearing signs of depression, well, that's what they'll give you. So it is great for the woman, and even the fact that you need an antidepressant confirms that you have depressing, and it can be depressing to know that you have depression. It's like sometimes it just doesn't help. I mean, that it's going to help, but it doesn't help in the same way. Whereas if you're thinking, oh look, I'm using Siberian ginseng as I don't have depression. I'm just using this to help even out the fact that I'm clearly going to be sleep deprived. I mean, how can you not be when you're breastfeeding a baby every 2 to 3 hours, 24 hours a day? Well, yes, you're going to be. Yeah, so it's almost less depressive, isn't it? And they can work so fantastically well without, all the nasty side effects that pharmaceutical drugs can do. So the last a couple of slides are talking about postnatal psychosis, and this is pathological. It is very abnormal. It is very rare, and it is very serious. Maybe I shouldn't say it's very rare. It is rare. It's very abnormal, and it's very serious, and it's rare. The symptoms of postnatal psychosis, usually by about a week post-delivery, commonly after the baby blues should be over, which you mentioned before, Anna. Yeah, postnatal psychosis can begin with symptoms that can be kind of very similar to postnatal depression, but they have these emotional highs that are in there, and they do vary from person to person, but they always follow a bit of a pattern. And which we're going to go through here. I know it's really fine print, but this is really so that people can, this is sort of the pattern that postnatal psychosis can run by, and it can happen really quickly. So there's kind of this golden rule with postnatal psychosis that however many days it takes to get diagnosed before treatment can begin, then that's how many months it will take to recover. It's horrendous. It can be horrendous. So this is when the serious drugs come out, lithium usually. And yeah, so let's say if it takes 10 days for that woman to be diagnosed with it, or 12 days, it's going to take you 10 to 12 months to recover fully. It's incredibly debilitating and serious. So to run through that sort of pattern of postnatal psychosis, it begins with difficulty with concentration and coordination, changing of mood swings from being very elevated to being irritable, restlessness, insomnia, horrendous nightmares, decreased need for sleep, fear of sleep, almost immense fatigue or endless energy. It's a real red flag, endless energy, and an inability to feel pain, such as Caesar stitches or episiotomy stitches. She's just not even feeling the discomfort. So that's why she's kind of over energetic, because her body's not telling her to slow down. And overactive, over enthusiastic, excessively cheerful behavior, feeling overly capable, like Superwoman, so excited and elated, rushing from one task to another, bossy and demanding, angry and aggressive if annoyed, agitated, almost suspicious. Now we start to get into some of the psychosis part of it, and she's getting a bit suspicious of what's going on. She's organizing grandiose ideas. You know, she might be thinking of a money-making scheme or excessive spending, or she's going to have this huge party to celebrate the baby, or it's all just going so busy. And she can be obsessing over things or having quite obsessive thoughts, hyperactive with racing, increased brain function, even actually improved math skills. It's like crazy. Yeah, the crazy is starting to come in. Distressing, delusional, false beliefs, that people are beginning to harm her. That's a common one. Sensation of improved ESP, extrasensory perception. So intuition, she feels like she's talking to God, or her son's the Messiah, or she's reading minds. And now we're really heading into the crazies. Uncontrollable urge to talks really quickly, strange ideas, bizarre delusions, severely altered and disturbed, frantic, hysterical reactions, overwhelming hopelessness or embarrassment or feeling of inadequacy. Obsessive religious beliefs come in, blowing out of proportion any pre-existing phobias, you know, of things like heights or sharp objects or insects or bee stings or animals or the cat, or the brakes are completely derailing on emotional response controls. Experiences hypersensitivity to outside stimuli, false sense of, you know, she's getting false taste sensations, etc. Abnormal perceptions, so she's seeing things like angels, or she's hearing imaginary things. Delusional voices commanding her to do profound things. You know, this is you know, walking down the street at 2 a.m. on a cold night in her nightie with nothing else. You know, she's like, we really lost the plot. And this woman is not well enough to be managing the care of her baby. She can't manage the care on herself. She's really, really lost it. And she needs serious attention, which, and it's the and you know, inpatient care, serious drugs, to help everything calm down and become more normal. And she will need counselling because often afterwards, when women are in the recovery from that, they're so traumatized from the fact that it even happened to them. 50% of the time, when a woman has postnatal psychosis, there is absolutely no risk factor. She has no history of mental illness. And to go from, being a happy, normal person to a psychotic nutcase, which is what it is, to be frank, is incredibly traumatic for that woman. And it has been traumatic for her partner. And he's now with someone she's a partner now with someone that's just lost the plot. And so it's a real horrible experience that a woman goes through. And there's several in every sort of 1,000 women that will occur to. And often they can go on, they really do that journey of being the victim, then the survivor, then the warrior. And they will often down the chat go on and form postnatal psychosis awareness groups and postnatal psychosis support and help. And that's part of their healing. What if, I know that you'll have commentary, Anna, you will have seen this yourself.
Yeah, and it can be really, I have had one case of this, and it was just extremely disruptive, of course, as you guys can imagine, to the family members. And what I would say is that, yeah, there is no really identified cause at this point. And for some women, like you said, Kathy, they don't have a history of mental illness. However, if there is a family history of mental illness, particularly postpartum psychosis, or there is a woman who's diagnosed with bipolar disorder or schizophrenia, or maybe have developed psychosis after the first pregnancy, these are definitely people that you want to make sure you are aware of, keep a close eye on them. And honestly, I don't think it really would harm anyone that around 32, 36 weeks really start to get the whole group of providers kind of together along with the family and come up with a plan in case it does happen again, because it can be so disruptive, and to help this woman so she doesn't have to go through it again if she has already.
Yeah, absolutely. Yeah, because although 50% of women have absolutely no risk factors for it, 50% do. So yeah, they are big red flags. And so one of the things that obviously there's those practical things like, making sure that your freezer is full of meals that you don't have to cook, and but all women should do things like that to sort of make sure that they've got the most stress-free time afterwards. But with these women, because they really need I'm talking these women, I'm talking about the women who have those real risk factors for it. They really should not be, how can I put it? Quite often what happens is in that first week or let's say 2 weeks, the partner may take time off work, and the mother's there, and the mother-in-law's there, and her sister's there, and everybody's there in that beginning week or two, and then suddenly everybody's gone. And that's the thing that is really not great for this woman. So I've said to women who have that history of anxiety or or some kind of depressive disorder history, I've said to them, say if your partner's off for 2 weeks, well, you maybe have the partner off for the first week, but maybe the second week they're part-time and the third week they're part-time. And rather than having mum and mother-in-law and your 2 sisters there as well, spread them out. So like just kind of spread that roster out over that first 6 weeks, so that basically every day somebody is popping in and somebody's going to be just checking on how things are going, and spread that care over that first period of time. I see that we are actually over time. They're such big topics. Yeah, so I've done a lot of talking there, so and we've had some problems today with the internet a little bit with Anna, but Anna, is there anything else that you feel that we've missed going through this brief overview that you want to add on to here?
I don't believe so. I mean, I think it was a pretty, despite the time, I think it was a good kind of overview. And helps people to at least identify, the difference between the different conditions, and kind of some of the women who might be at higher risk. So I think overall it was a great presentation.
Okay, well, that's wonderful. Look, our details are there, and of course, IMCO, we're here, and you can, there's a whole huge array of, webinars, of course, that we've got there as well. So look, just thank you to those who are live here today with us, and those who'll be watching later on and using this as a resource. And I want to wish everybody a lovely rest of your day and rest of your week. And thanks, Anna, for being here with us today. And want to say goodbye to everybody and farewell. So thank you, everybody. Thank you, Anna.
Thank you for having me. It was a pleasure. And sorry for the internet issues.
No, if it wasn't you, it's me typically. All right, bye, everybody. See you.